Well, I'm excited to launch a sort of a mini podcast series with you, Larry, on what I think we both would agree is a very important topic in the rehab industry right now, and that is compensation. How do we actually effectively compensate rehab professionals? By way of introduction, probably good to start off with some introductions for those that are going to be listening to us and watching us. So I'm Jason Wambold. I'm a physical therapist. I've been a physical therapist for 26 years, and I am the founder of Prompt Compensation. This is a platform that we've been utilizing for the last 12 years to help the industry come up with a better way and a more transparent way to effectively introduce variable compensation models that are designed to really positively impact the profession and cause therapists to actually want to remain therapists. So that's my background. Let me give you an opportunity to introduce yourself.
Sure. Well, thanks for inviting me, Jason. It's always it's wonderful to be here at the Prompt PT headquarters. One place, what good vibe, a good culture, and it just exudes a lot of energy here. And I was here one other time. Just really enjoyed it. Happy to talk to you about how we pay our therapists. It's a byproduct of the industry of reimbursements, of the business of PT, if you want to go there. And it's really, really critical. And I think we're at a time of immense challenge to margins of the business to be able to be viable, especially in outpatient private practice that is unaffiliated with a hospital or an institutional setting. By way of background, I'm a PT as well. I always think of the Ben Franklin tombstone. It says Ben Franklin painter. And I hope to always be known as I'm a physical therapist. I started my career as a military PT. U.S. Army Baylor program. I've been a PT 40 plus years. Once you're at the 40-year mark, by the way, you don't go 41, 42, 43. You just
40 plus.
40 plus. And I've been in all aspects of PT. I worked in inpatient, outpatient. I started a physical therapy business in the mid to late 80s, and had a lot of outpatient clinics. And we transitioned that business very effectively. And so I stayed in the educational sense, the outpatient PT clinic. I'm probably most recently known as the founder of Confluent Health, where I'm still a largest individual shareholder there. And Confluent Health has 850 plus clinics that are either wholly owned or joint ventures with private practice PTs. We have a hospital, contract therapy company. We have a network called PTPN, an on-site industrial company called Fit for Work. And then we do a tremendous, amount of work in the outpatient PT environment. So I migrated from founder, CEO of that company to more of a founder role. And now in my spare time, I'm also working in the dental world. I work with a private equity group that owns a very large dental partnership organization or dental service organization, DSO, called Dental Care Alliance. And so it allows me to stay in the PT world, but also get a perspective and learning some new additional things of the dental world. So it's quite a bit of fun, and I've really enjoyed it. But there's nothing I like more than talking about all things physical therapy.
Yeah. Well, I appreciate and have appreciated our conversations up until this point, because I think this is a conversation that needs to be had across the industry. And I'm excited that you're willing to partner with us in this podcast series to help us really look at and dive into what we should be talking about. And what I'm excited to do here with you is to really dive into some of these topics that might be uncomfortable. Mm-hmm. And I think those are the types of things that we need to actually dive into. So starting with that, I thought we could kind of wind the clock back and talk about how did we get to where we are today. That would probably be a good place to start. If I think back in my own career, if I go back 20, 25 years ago, interestingly, a couple things were different and they stand out. The first of which was, I don't recall, and I'm curious to hear your perspective on this, I don't recall running into very many therapists that I knew personally who were specifically looking for part-time roles, or therapists who were specifically looking for a work structure that enabled them to work under 40 hours. A specific number of hours they were looking to work, 31 hours, 32 hours. Today, that seems to be, in my opinion, and from my perspective, more the norm rather than the exception. So my question to you is, have you observed that as well? And if so, what would be your sort of theory on why you might be seeing that?
Yeah, it's interesting. Outpatient physical therapy is a very young industry. if you really look at when it got endorsed, it was probably in the mid-'60s with the advent of Medicare Part B, enabling PT to bill and get paid for services, primarily modalities.
Yeah.
And so from that, you started to see a growth in outpatient PT in hospitals, and then private practice started to come and be a thing.
Mm-hmm.
And private practice in those early days was a very, very niche, the part of all of PT. It still is. I mean, up until a few years ago, I used to say that half the population doesn't know that outpatient PT exists, and the other half of the population can't remember where they went to physical therapy at. And so the business has changed, the migration has changed, the reimbursement has changed enormously, but the supply and demand has changed more profoundly. And so we've had these various inflection points. And I think you have to look at the COVID period as one of those inflection points. Up until 2001, physical therapy programs started to grow pretty considerably until we got to where we were graduating about 5,000 PTs a year. That's not that many. However, there would be 10,000 physical therapists in the U.S. system. There would be 10,000 foreign trained therapists come in. Half would pass the exam. And so we had a supply of 10,000. That's a significant supply. After 2001, major inflection point, it got reduced to half that because all of a sudden foreign trained therapists were no longer welcome in the U.S. When that happened, the shortages just took off. And so all of a sudden PTs could work where they wanted, when they wanted, and for whom they wanted. Mm-hmm. And they could switch jobs as often as they want and never be unemployed. And I think you have to look at that as sort of the genesis of what you're saying, which is now we have a generation of PTs that want to work less and they want work-life balance. And they've seen the effects of COVID and they've seen the effects of hyperinflation that we had just a few years ago. And they're fearful. They've also seen the impact of student loans and all the things that go with it. So that has had, a profound effect on it. I think the other thing that's changed is reimbursement as a practical matter hasn't changed in the last 10 years.
Yeah.
In fact, on a nominal basis, Medicare actually pays us less than they did 10 to 15 years ago. And so you have this sort of inability to increase prices. You can increase your prices, but you're going to get paid this certain amount. Then you had hyperinflation and purchasing power, plus therapist wages went way up, and the shortage also was significant. And so the employers reacted by saying, I'm just going to give employees anything they want. You want to work 31 and a half hours, so be it. You want to work there. And I think that type of culture and atmosphere was caused our current status quo. And it really has, exponentially impacted the profession, because now it's a very, very difficult business to make any kind of reasonable margin, because you have high turnover, you have burnout, you have an industry that, to my knowledge, I don't know any other profession where our production has actually been reduced. Our productivity has been reduced because of the impact of the regulatory side of it. All of those things are pressure points to an industry where now we're effectively allowing our new entrants, the PTs, now we're up to graduating 12,000 PTs a year. Mm-hmm. And unfortunately, call it a percentage don't pass the exam. A large percentage don't ever even go into clinical practice. And so you have an addressable market of like 70,000 PTs. Combined section meeting coming up, all the descendants and their talent acquisition groups that are $1 million built out groups are going to be going after those PTs. And guess what? They're not going to interview them. They're going to be offering them jobs. They're not going to have to go through a process and really get somebody who they want. They're going to get somebody who's got a pulse.
Yeah.
And that has a profound impact. So I blame everybody. I blame the schools. I blame the employers. I blame the individual therapists having unrealistic expectations. And I blame the education system, higher ed, predominantly because you have high cost, and therefore high student debt.
Yeah, there are certainly plenty of challenges, and I know we're in a future episode, we're going to get into some solutions, but there are a lot of challenges to unpack. One of the other ones that I think of is this idea that many therapists have when they graduate from school and they do go into clinical care, that they're going to be paid either by the hour or perhaps a salary. That's really the only mindset they have. And specifically, one of the things that I've noticed recently is I've run into more practices that are paying their therapists by the hour than any other model.
Interesting.
I'm curious to hear your thoughts on that because, again, just from personal anecdotal experience, that was not my experience, say 20 years ago. The vast majority of therapists that I knew, unless perhaps if they worked in a hospital setting, but outside of that, therapists were salaried professionals. Now, there are some challenges with that approach, and we'll talk about that, but they were salaried by and large. Today, what I run into is more often than not, therapists who are being paid by the hour. So I want to ask you two questions about that. A, has that been your experience as well? Have you run into that? And also, you have experience in other healthcare industries. As of right now, you actually have direct experience in the dental industry. So I'm curious if you can compare and contrast what you're seeing in the physical therapy space with regard to hourly compensation models and other healthcare industries such as dentistry.
Yeah, there's a tremendous amount of consequences of shortages. And those consequences are employers have reacted predominantly by a spattering of offers, including I'll pay off your scholarship, I'll pay your student debt, I'll give you a sign-on bonus. I've seen cars being offered. I'm not surprised that you're seeing hourly amounts. I personally, California is the only state that I know where you have to pay PTs by the hour because the state in California, PT is it's not even a profession, it's an hourly worker. Find me a profession that is a billable minute, like the law profession, where you have more pressure, more depression, more, all kinds of psycho effects, including burnout. I don't like the idea of PTs coming out and expecting a certain compensation or an hourly amount because employers react to that and it just compounds the problem. Most professionals, and I go back to physical therapy, has predominantly become a business that is supported by clinicians. Dental, medical is a clinical service that is supported by business. It's a big difference. And so if you're a dental professional or a primary care physician and you're in a management service organization, the laws basically say, the corporate practice of medicine say, a company cannot interfere with the clinical decision making. In fact, they can't own the docs. They have to have their own professional corporation, and that has to be a professional, a doctor or a dentist. Yeah. We have those roles in physical therapy, but outside of New York, they're not obliged at all. Mm-hmm. And I'm a big believer we have to go back to that so that we can have a clinical, leadership supported by business, revenue cycle management, technology, all the things that you need to support the business, where now the business is being supported by PTs.
Yeah.
All of that has diminished physical therapy. We're not a doctoring profession. We aspire to be. Mm-hmm. But how many doctoring professionals come out and they're paid by the hour? How many come out and they're not paid on somewhat of a production model where they get a piece of what they produce?
Yeah.
And all of these effects have become culture. And they become normalized. So it's very normal to expect these kind of things. And unfortunately, it has consequences. Those consequences are we're not a doctoring profession. We're really not an independent clinical decision-making profession. We can reverse that. We have the power to reverse it. But I believe a lot of that has been created by the shortages and employers really believing that the widget maker PTs are there to support their business rather than the contrary of that.
Yeah, if we look at small privately owned practices versus larger multi-state entities, do you think it's more, if we look at those practices, which by and large are paying their therapist by the hour, do you think it's more that small private practice owner is saying, I would prefer to pay my therapists a salary, but they're coming in asking for an hourly rate, and as a result, I'm going to pay them an hourly rate? Or do you think it's the bias that the actual owner has, where the owner is thinking, I need to pay these therapists by the hour for whatever reason? One of those reasons might be to control cost. If there isn't a patient there, I get to send my therapist home, I get to save some money. Regardless of what the reason is, chicken versus the egg question there, what do you think?
Yeah, not 100% sure because I don't have a lot of experience in paying therapists hourly unless they're part-time. I will tell you that if the idea behind paying therapists hourly is to control costs, it's not a good mechanism to control costs. The only mechanism to control cost is variable compensation. So if you talk to most practice owners, whether they're paying them salary or whether they're paying them hourly, I believe they look at compensation as a fixed cost. The reality is, and you could look at any accounting book, it is the most variable cost you have in a business is your labor, because you can spike it up or down depending on demand in theory. And so the way to control for that is through a variable mechanism of compensation. I know we're going to get into that at a later point in terms of potential solutions. So if practice owners are doing that, it's not a good sound business decision. If that's the expectation, maybe it's driven by the schools. Maybe it's driven by the academic side, which says if you go out to an employer and they're not offering you a good hourly amount, or they're telling you have to see many patients, run. And so maybe there's been an imprinting or indoctrination. Regardless, the culture has to change. The culture has to be more of, if we're going to be a doctoring profession, we're going to be clinicians, and we make our compensation through clinical work. What have we historically done in PT? The way we've elevated compensation is to drive you out of the clinical realm. Yes. We bring you in to become a clinician. We train you to become a board certified therapist. You're on a compensation model, which is typically a salary. Oh, how can I pay you more? I'm going to make you a clinic director. Oh, when you're a clinic director, you can't see patients 100% of the time. Yep. The expectation is 80%. Yep. Oh, you're a good clinical director. Let's make you a regional director. Now you're down to 20, 30% of a clinical time, but you're making more money. Yep. And those things do not add up. Yep. A true doctoring profession does not have their own doctors as clinic managers, regional managers, and the like. Yeah. Find me an orthopedic surgeon who's a clinic director, who's a regional manager of other orthopedic clinics.
You can't.
It doesn't exist. And so what you have to do is you have to shift the paradigm back to the clinicians or the money makers. We have to pay them more. It's not that complicated. If a true doctoring profession doesn't need to be coddled, they don't need regional managers. Now, if you have a clinician that's working in a region that's a clinical facilitator that goes in and works with the clinicians on more interventions, higher order next skills, critical thinking skills, manual therapy skills, that's not what they're doing. They're doing business. They're helping choose the carpet of the next de novo. They're helping them order equipment. They're helping them replace the front desk person. They don't need a PT to do that.
Yep.
What you need is your PTs to make more money by seeing more patients. When they can make money seeing patients, they'll never want to be a regional manager. Yep. They'll never want to be a clinic director. Yep. That's, again, does the business support the clinicians, or is the clinicians there to support the business?
Yeah. Yeah. We will not have any trouble running out of things to talk about with regard to challenges, but there's another one that I definitely want to make sure we hit, and that is this concept of burnout.
Yeah.
Work-life balance, burnout. One of the things that's very interesting, I had the opportunity to speak to a group of third-year PT students recently. And I asked them, what is the primary concern that you have? What's on your mind? What's your primary concern as you get ready to graduate and get your first job? I thought that what they would say is, how do I repay my loans? That's what I was anticipating that they would say, this debt to income ratio imbalance that we have. That's not what they said. What they said is, almost across the board, I'm worried about burnout. That was their primary concern. They're not even licensed therapists yet, and they're worried about burnout. They're worried about maintaining their work-life balance. I'll give you my take on that, and I want to hear your take on that, see if it's different. From my perspective, a sense of burnout is not a virus that you catch. I experienced burnout. It showed up one day, and there was nothing I could do about it. It's also not tied to volume. I think we very often, certainly those of us that are hiring and recruiting and trying to retain therapists, think of this concept of burnout. Let's make sure I don't ask my therapist to see too many patients, because then they might be burnt out. From my perspective, burnout is a function of a lack of control. It's a feeling that you're a cog in the wheel and you have no control. You have no say over what your day looks like. Someone else is giving you certain metrics that you need to hit, and you have no say in the matter. Regardless of whether that's 5 visits a day or 30 visits a day, if you feel that you have no control, you could be seeing a low volume of patients and burn out. Or you could be seeing a higher volume of patients and feel certainly perhaps tired at the end of the day, but very fulfilled because you chose to see that volume of patients. So in my mind, burnout is tied to choice, not volume. What's your take on that?
Yeah, and first of all, I would agree with you, but this is a multifactorial thing, and autonomy, purpose, and the like is one aspect of it, and control is a big component of it, but it's more than that dimensionally. And so I look very classically at burnout, and I think, unfortunately, burnout has been conflated with fatigue and with depersonalization. The real definition of burnout is I no longer get a sense of accomplishment in the work that I'm doing. I no longer have any joy of doing this. Burnout is almost like a diagnosis. Okay, it does not have an ICD code with it. Don't get me wrong, but it has a complex of symptoms that are pretty consistent. The more I do, I'm not getting any joy out of it. I see no progress with it, and we have to look. There's all kinds of burnout inventory checklists. The Maslow's the biggest one, but there are other shorter ones where you could actually diagnose burnout. Okay, what I think people do is they conflate it with fatigue and depersonalization. We're in the relationship business. We work with human beings. And so as your day goes on, you have a natural tendency to what is called calcification. A lot of this research comes through call center research where you're dealing with a human being, but through a phone. And so you become numb to the fact that there's a human being on the other side of the desk from you. And that is called calcification. And so you have to decalcify. You have to take pause breaks. You have to take refreshments. You have to take whatever your thing is, maybe it's listening to music, and you have to get away from a real human being in order to come back and recognize that there are three dimensions. That's life. That's normalization. Now, burnout is very real and has those other complex set of symptoms, but here's what we're finding now is that they come into a clinic, and I don't blame the employers for this. I blame the system for it and how we train therapists. They come in, and a certain number of them are already burned out.
Yeah.
That didn't happen 20 years ago.
Yeah.
Physician literature cites the same thing. By the time they finish medical school, they're burned out.
Yeah.
And so all of a sudden, I'm a new employer. I finally paid all this money, sign-on bonuses. I had a big booth at CSM. I've spent all this money to get a new PT. By the way, I'd rather have PTs get that part of that big booth money. And now all of a sudden, I got a PT, and they're burned out. You should absolutely, in your interview process, determine if somebody is a burnout. I'm not saying you should hire them. I'm just saying you need to intervene more. And that's why the turnover effect is very, very high. So burnout is extremely real, and we have to deal with it, as an employer. The reality, though, is there are better ways to deal with it on a way. And exactly what you said, autonomy, mastery, purpose. Give them some sense of control. Get them to be master clinicians. The goal when you come into our organization is to become a master clinician. That is best exhibited by becoming board certified, but not only. You're going to take an advanced set of skills, you're going to upskill, and you're going to become a master. And purpose, we're going to constantly remind you what you do is important, meaningful work. It makes an impact and a dent in a human being who come in and they can't run, they can't walk, and now here's what you've done. You got to constantly remind them. So autonomy, master, purpose, right? Unfortunately, though, what employers do, and that's where I'm going to blame employers, what do? They have BI tools. They'll say, the BI doesn't lie. You're not billing enough units. They send them micro-pulse surveys every other day, or and information and dashboards tell them how unproductive they are, tell them that they're averaging 11.2 patients, and they need to average 11.4. By the way, I don't know where you're going to get that 0.2 of a patient, but if you find it, let me know. And those constant reminders are little reinforcements. Think of macro calcifications that contributes to burnout because you've taken away autonomy, you've taken away mastery, you've taken away purpose. There's ways I think you can deal with it, but that is absolutely part of a macro challenge that's happening. I think if there's any good news, I think over the past year or so, I think we saw this huge increase in burnout, and I generally sense some stability right now, which is good. So employers are learning.
And along those lines, one of the things that we see in feedback from staff therapists, and when we interview therapists who have left clinical care, which is something else that we definitely need to talk about, because there are more options than ever for therapists to not be in clinical care, separate from being promoted to a clinic directorship role or something of that nature. But one of the things that we typically see is therapists say, I left clinical care because I didn't see a path to my own growth. I didn't see a career trajectory for me. So How would you respond to that when we do hear therapists who say, I get that I could move into a clinical director role. I'm not interested in that. So in your mind, is that where a master clinician comes into play in order to give that therapist a clear and distinct path towards some sort of career growth that would keep them in clinical care?
Yeah, so it's a very good question. Generally, and I'm chief guilty officer of all this, generally we brought PTs into a bifurcated path. One is a clinical path. Well, they both start out on a clinical path. Yeah. The clinical path is you become a master clinician. And in our culture, that meant residency. And we would not even hire PTs unless they were committed to, within the first 6 months, entering a residency, becoming board certified. And that's kind of a 1 to 2 year process, right? And unfortunately, what we did in the specialty world is we said we could facilitate that by going faster. By if you do a residencies, it used to be 18 months. Now they're a year, you become board certified. We should have lengthened it, right? Because that would have kept the therapist in a more of a clinical role. And then if they stay in the clinical realm, they don't have a business or leadership, acumen or aptitude or, anything around that. Then we say you could teach in our fellowship program, you could teach on weekends, you could become a clinical facilitator, you become a clinical instructor, or you can go in academia. Okay, that's a really good pathway, and that pathway should absolutely continue. But then we said we have a second pathway. And your second pathway is the path to sort of ownership, right? It's a path to becoming a good master clinician. Then we're going to make you a good leader and a good manager. You're going to manage a clinic, and then you're going to be a regional manager, and you might even own part of it. Guess what we do in that pathway? We take them out of being a clinician. Yeah, chief guilty officer here. I'm doing the same thing. I would absolutely reverse those by making the clinical path the pathway to ownership and the priority around compensation. I would still make this other path available, but the further you go to it, you're going to actually get paid less, not more. And what is the unintended consequences of this? In our profession right now, call it 300,000 PTs licensed. I know those numbers are hard to come by because you have therapists that are licensed in multiple states. On an FTE basis, and I run these numbers, on a full-time equivalent basis, only about 20 to 25% of our PTs are full-time clinicians. What is it in primary care? What is it in dentistry? What is it in orthopedic surgery? Doctoring profession versus a profession who we're doing all we can to take you out of a doctoring profession.
Yeah.
I spoke recently at the Graham sessions, asked people by show of hands, didn't ask them to actually raise their hands, how many people in that room are full-time clinicians? Very few, virtually none. If I was speaking at a dental or a primary care Graham sessions, and I said, how many of you are seeing patients? Well, that's how I make my money. That's my job.
They would almost look at you funny with that question, like, well, what do you mean? Why would I not be treating patients?
Exactly. What would I be doing?
Right.
What else would I be a regional director?
Right.
Yeah, exactly. And so all of that unintended consequence has been horrible on the clinical culture around master clinician, and how we make our compensation and our living is by seeing patients and getting them better. We have put all these negative feedback loops to take people out of the end. Nurses have had, very similar challenge, although they're not technically a provider like PTs are. And so that's the cultural shift. If we're going to get compensation and other things right, like we're going to talk about later, we got to get the culture and the normalization. The normalization is you're going to be a clinician your entire life.
Yes.
I'm 63 years old. How many 63-year-old clinicians do you see? Not a whole lot.
Yeah.
Right?
Yeah.
Good. I'm one of the non-clinicians. I started out as a board-certified PT in both orthopedics and clinical electro. Mm-hmm. Less than 3% of PTs are double board-certified. Okay. What had happened to me? Well, I found opportunity in the business side of it. And I had good acumen towards it. And I went on and I got an MBA. And I went on later and I got a master's in applied positive psychology to learn about burnout and positive psychology that can be transported into our profession to help our clinicians. But I'm an example of somebody who came out of the clinical realm. You're an example of somebody who came out of the clinical realm. Not right or wrong, but we were almost incentivized to, because that's the only way we could have made more money.
Yes.
And we have to reverse that.
Yes. Yes. And I think that's a great segue into what we'll be talking about in the future, because you're in our next session, because you're absolutely right. We have to come up with a way to make it. And if I had this, my trajectory would have been different. We have to come up with a way to make it attractive, certainly financially, but otherwise, to stay in clinical care. And right now, what we do is we make it attractive to leave clinical care. And then we wonder why we don't have enough providers. So I think this is a great time for us to transition over to our next section where we will actually be talking about what to do about these challenges. There are plenty of challenges, but I think we would both agree that there's lots of untapped opportunity where we can do exactly what we just said. Make it attractive for therapists to want to stay in clinical care. Yep.
100%.
So I look forward to talking with you about that topic.